for the module on epidemiologic study designs. This is the second lecture segment addressing the randomized trial. So, as I said in the first lecture segment, I really think of epidemiology as the realm of observational studies and not randomized studies. But usually epidemiology courses and textbooks do say something about randomized trials, and we are going to talk about that here. But a very important thing that we want to keep in mind as we think about study designs in epidemiology is how do our observational studies deviate from the randomized trial. So the randomized trial, in terms of research on human beings, randomized trials are really the best that we can do, the closest we can come to that counterfactual, the best evidence we can get for cause and effect. So we're going to talk a little bit right now about what a randomized trial is, and then in the other segments for this module, we're going to talk about the other study designs and think about how they deviate from a randomized trial, how they do not achieve what a randomized trial can achieve. So really we're starting with randomized trials as kind of an ideal, and then we'll talk about the others as approximations of that better approach. So a randomized controlled trial, the key features are that an investigator assigns an exposure or treatment status randomly to study subjects. They may be individuals or they may be groups. And then those subjects are followed over time to ascertain their outcomes and to compare the outcomes among the exposed and unexposed, or compare the treated to the untreated. So in a randomized trial, you're going to start with a source population. You're going to select the people that are eligible according to whatever definition works for your study of eligibility. And then those subjects are going to be randomly assigned to a treatment or intervention, or to the untreated or control group. So once that randomization has happened, now you're starting the period of follow-up time for your study. And then you're going to observe those subjects and determine who has the study outcome, which of the treated people are diseased and non-diseased at the end, which of the untreated are diseased and non-diseased at the end. So pretty simple, and I know that many of you have read enough biomedical literature that it's fairly clear to you what a randomized trial is, but I just wanted to spell out all those terms and steps, because again, we're going to talk later about how observational studies differ from this design. Okay, so when we're randomizing individuals to a study, some examples of situations where we might use that. So we might be doing a randomized trial of a new medication, and that's maybe the one that most obviously comes to mind. A new medication, a new medical procedure. We're going to do a randomized trial to see if it's superior to the current practice for the same set of eligible patients. Actual interventions by physicians or by healthcare providers are not the only areas where randomized trials are used for health research. So you might have a randomized trial of dietary modification. You might have a randomized trial of an exercise program. Those might not be carried out in the clinical setting. Those might be carried out in the community setting, or they might be carried out, within a healthcare system, but not among patients presenting with a specific condition or complaint. There are also really important randomized trials of screening programs. The concept that early detection will lead to better outcomes is tested in so many areas with trials of screening. And again, sometimes those are not even clinic-based, sometimes those are community-based. And then there are randomized trials of smoking cessation. So really, there's a lot of different areas where randomized trials are applicable. However, as we've talked about, there's of course a lot of things that affect human beings' health that we're not able to randomize them to. But back to the randomized trial, there also is the first set of examples you might be randomizing individuals. There also is this idea that you can randomize groups of people. So in this example, an investigator assigns exposure status randomly to groups of individuals. And this is where there's some natural grouping that already exists. If the investigator is creating the groups, it's really a regular randomized trial of individuals. But if those groups already exist and it's more convenient to implement the intervention on a group basis, then the groups will be randomized and the groups will be followed over time to ascertain outcomes. So examples of where that might be applicable would be if in a particular area of health practice, there's some new idea of how to manage a certain type of patient, some kind of change in clinic practice. And sometimes it's considered hard to randomize like one physician to do a new procedure or new practice and another physician right down the hall to stay with the old one because they're going to talk to each other. So sometimes the entire clinics are the unit of randomization for a study. I'm actually aware of studies where health studies, again, for health behavior, for prevention, where the intervention takes the form of a media campaign. When I was growing up, we had those ads about that smoking was bad for your health. It was actually a relatively new concept in those days to use TV to give this public health information out. And so there are examples where public health interventions are actually randomized to test them, and the unit of intervention is often a community, a city, some large group like that. The original studies of fluoridation of water supplies, obviously they did not randomize individuals to drink different water. They randomized community water supplies to have different water in them. Or if one was going to study that, that's how one would do it. And again, screening programs, I put both in the individuals and the groups. Those have been tested in group settings too. So I think that the individual-based randomized trial is probably the simplest and the most familiar to you if you've done a little bit of reading in the medical literature. But this idea of a group trial, I just always like to point it out because it has some very interesting applications. All right, so once you've done your randomized trial, you're going to have some data. What are you going to do with those data? Or to put it another way, someone else has done a randomized trial. What are you going to see? So this layout here is what we call a 2x2 table, and I will show you many of these throughout your time in this epidemiology class, and if you take the next one, same thing. A lot of 2x2 tables. So what this table is structured as is, first of all, the treatment status. Was the person randomized to the treatment, yes, or the treatment, no? And then what was that person's outcome by the end of the study? Did they have the study outcome, whatever that was, or not, yes or no? So here you've got 4 different categories in this 2x2 table. A, B, C, and D are just going to be the number of people that fall into each of those cells. So that's how we're going to organize in the simplest way the data from a randomized trial. As we talked about in the lecture on measures of disease frequency, if you're using a count denominator, you can then calculate incidence in each of those groups, the treated yes and the treated no, from this table. But if you do not have a closed cohort, then you may need to go to a person time denominator, but still we can think about it in a 2x2 table. Among the treated, how many person years of exposure were there and how many individuals had the outcome to calculate the incidence. And then in the untreated, same thing, how many person years of exposure, how many had the outcome. So that's sort of just the really simple conceptual way of laying out data from a randomized trial. Most publications do not treat it this simply. They do some more elaborate things. So I just picked an example of a study from a number of years ago. This is from the Women's Health Initiative randomized trial of estrogen plus progestin in healthy postmenopausal women. And the primary hypothesis of that study, of course, was that the estrogen plus progestin hormone replacement therapy would prevent cardiovascular disease events and cardiovascular disease deaths. And so this is actually from their paper now. This is how they organized their data. So it doesn't really look like our 2x2 table anymore. So now the exposed and the not exposed are now the columns, right? The treated with estrogen plus progestin, the treated with placebo are the columns of this table. And that's still our exposure or treatment, yes and no. And they give us the total N. And then they give us the number of patients that had each outcome, with the outcomes being in the rows. And then they calculate the hazard ratio, which is appropriate for this type of data because they do have a person time denominator. But that's something that we'll talk about in the lecture on measures of association. So again, the idea being you've done a randomized trial, you've got in the simplest type of study, you've got 2 statuses, treated and untreated or exposed and unexposed. So you organize your data according to that, and you look at how many number, or in this case, what percentage in the parentheses. So for instance, If you look at the third row, CHD death, there were 33 CHD deaths, or 0.07% per year in the exposed, the treated group, and then there were 26 CHD deaths and 0.06% per year in the placebo group. So not very much difference in that important outcome in this study. So again, just an example of how people might present their data, and we'll talk again more about this in the lecture on measures of association. So why would you use a randomized design? Well, a randomized trial is really going to be the best alternative to that ideal counterfactual design when you're dealing with human subjects. It's also the best design for control of confounding. By randomizing subjects to treated and untreated, any possible variables about those patients or variables about those participants that might be different and it might affect their outcomes, once you've randomly assigned treated and untreated among the people, all their differences should sort of average out. We'll talk a good bit more about confounding in another module in this course as well. So a randomized trial actually also reduces the opportunity for other biases. In a randomized trial, you can directly measure the incidence of disease, and that's going to be contrasted with the case control study that we'll talk about later. And in a randomized trial, multiple outcomes can be studied. So that example from the Women's Health Initiative, not only did they look at CHD deaths, they looked at actually many different outcomes. Once you've got your population of people and you're following them, you can look at a lot of different outcomes in relation to your same causal treatment, your hypothesized causal treatment or exposure. All right, so randomized trials sound pretty awesome. But what might be a problem with a randomized trial? First of all, many exposures cannot be assigned randomly. So the reasons why you might not be able to randomize might be feasibility. So genes, you can't randomize people to have a certain genetic mutation and other people to not have it and see if it really causes disease. SES, or as we in epidemiology, and people in social sciences, SES meaning socioeconomic status. You can't really randomize someone to be born in one household and randomize someone else to be born in another household. That's really not going to fly. That's not in your control. You can't usually randomize people for something like body weight. If we want to know, what the health effects of obesity and overweight are, we can't really randomize people to one of those conditions. So feasibility is one reason why not all cause and effect questions are addressed with randomized trial. Another reason why some exposures cannot be assigned randomly is ethics. So if a treatment has a known harmful or beneficial, is known to be harmful or beneficial for another outcome, if a certain drug is known to be very useful for people with this severe condition, you can't really randomize them to get it or not get it in order to know some other secondary effect of that treatment. You would need to go to an observational study for that. Over the years teaching this class, I've had a number of maternal fetal medicine fellows, and they say that it is very hard to get any kind of randomized trial of medications in pregnant women. Even though medications are given to pregnant women, medications are prescribed to pregnant women, the idea of randomizing them is just considered ethically problematic, or at least they believe it's not going to be accepted by the medical community and by the patients themselves. So you're going to be asked in this course to give an example of some kind of question in your field that you're not going to be able to, that a randomized trial could not be done. And so just think a little bit creatively. I bet it will take you only a couple of minutes to have an idea about that. And that'll be a discussion assignment that you'll be posting and see the other people's examples. Okay, so what other problems are there with randomized designs? There's non-compliance. There's switchovers and dropouts. Again, in quite famous studies of whether taking a small dose aspirin every day would prevent heart disease and heart disease deaths was a very large. It had to be a very large trial because they had to start with a healthy reasonably healthy population and wait for them to have cardiovascular disease events. So very large population, randomized a tremendous amount of people, and then they found that people were switching over, either that someone was using aspirin for another reason besides whether or not they're randomized to it in the study. They had arthritis or migraines, or they started using NSAIDs or whatever. And then there were people who didn't tolerate the aspirin and dropped out. And so there's many other examples of subjects who do not end up staying on the treatment arm that they are randomized to. So that's a real challenge in randomized trials. Okay, and finally, randomized trials may be unwieldy to carry out. So the example I gave you of the randomized trials of aspirin, it took a huge number of study subjects. Studies may take a long time to follow up. They may be expensive. But I have to say, nowadays, most studies get kind of expensive and challenging to carry out. So that's not a reason to not do them. But anyway, the main thing for us in an epidemiology course is to think about the fact that the cause and effect questions that we're interested in, usually that first bullet, we can't actually randomize people to certain types of exposures because of feasibility or ethics. So that's what's leading us to the observational study designs.